the next two talks. One is optimizing the ocular surface to do all the biometries and aberrometries. And the second one is going to tell us how to interpret the aberrometer.
Good morning, dear friends. I would like to thank John for inviting me to this program, the ISSO program, and it's very nice interacting with all of us. Today I'll be speaking on optimizing the ocular surface and also on corneal topography before cataract surgery. So let's So I think this is better. I don't have to bend over. So let's look at the first topic, optimizing the ocular surface. And this is something which is very important, which was neglected in the past. And let us look at the impact of pre-existing dry eye on cataract surgery outcomes. The incidence of ocular surface disease in cataract surgery patients has been reported to be almost 33%. And in one study, Trackler et al. Reported 77% of patients scheduled for cataract surgery having positive corneal staining. Although dry eye was just previously diagnosed in 22%. So the 22% is just the tip of the iceberg. 77% of patients coming to you may have some amount of dry eye. And OST significantly affects visual outcomes of cataract surgery, and the cataract surgery may actually exacerbate pre-existing dry eye and the patients. This is one of the major reasons for patient dissatisfaction after cataract surgery. So therefore, identifying dry eye and treating it effectively before performing cataract surgery is essential to get good patient satisfaction. You may give them 20/20 vision, but if they have dry eye, then usually these patients are unhappy and complaining. If you look at, these are the two papers which looked at effect of tear osmolarity on repeatability of keratometry and tear film abrasion dynamics, and it is found that dry eye affects repeatability of K readings. So your K readings can be off, so your biometry is off and your post-op refraction also is off. It also increases the higher order aberrations, which actually worsens the quality of vision. If you look at the mechanisms of dry eye, it's quite complex, but it's a vicious cycle. It involves tear film instability, hyperosmolarity, apoptosis, inflammation, and they are all interconnected. There are a lot of contributing factors, and it makes it worse. And one of the major causes of tear film instability is NG. The ACRS have a preoperative OSD algorithm, and it's a step-by-step approach to dry eye patients considering cataract surgery, and you can go through this algorithm and also use that. But let us look at a practical approach. First, it's very important to take the relevant history. If there's coexisting conditions like diabetes mellitus, connective tissue disorders, thyroid abnormalities, or hormonal imbalance, because all of these can contribute to the OSD. Some of the older patients coming to you may have a history of prolonged medications, either topical or systemic, and you have to take a history of those. There can be a history of prolonged dryness of the oral cavity or recurrent mucosal ulcers, especially women, so this is also something that you need to consider, and ask for history of joint pains and joint aches, because they may point to rheumatoid arthritis and dry eye. Some of the medications contributing to dry eye disease, systemic, most of the patients can either be on antihypertensives. Hypertension is very common, so you have to take a history of this. Anti-androgens, anticholinergics, antidepressants, cardiac arrhythmia drugs, antihistaminics, and biphosphonates. All of these can cause dry eye. Topical, many of the anti-glaucoma medications and the other drops which have preservative can increase dry eye. So apart from topical medications, you also have to ask them about contact lens use. Some of them, especially the myopes, may have been using contact lenses, and they remove the contact lens when they come to the clinic. So it's very important to ask history of contact lens, like Dr. Ram was saying, that it's very important because again your K readings can be off if you have corneal warpage. You also take an ocular surgery history, especially the history of refractive surgery is very important, LASIK or PRK, etc. History of any ocular surface disease or eyelid surgery. The ACRS has a speed to pre-op OSD questionnaire which is quite complex. You can use this preoperatively if you want to do a detailed history and assessment of dry eye, because dry eye is assuming a lot of importance nowadays in the pre-op evaluation of cataract surgery because it influences outcomes and also patient satisfaction. So ocular examination, you have to examine the eyelids, look for entropion, ectropion, you avert the lacrimal puncta, look for cicatricial malposition. Look very carefully at the anterior and posterior lid margins, abnormalities of myopian glands, rule out blepharitis because MGD is one of the major reasons for dry eye. Look at the adnexia also, lacrimal enlargement, look for any proptosis or pseudoproptosis and cranial nerve dysfunction, trigeminal or facial. You can also assess the myopian quality and grade them, grade it into stage 1, 2, 3, 4 of MGD or a plus disease which can have coexisting lid or ocular surface disorders. And it's very important to look at the glands. Some of the slit lamps, like the top one that Dr. Ram was showing you, have an infrared camera, so you can actually look at the myopian glands. If you don't have an infrared slit lamp for assessing the myopography, then you can avert the lid and use your autorefractometer. The autorefractometer has an infrared camera and you can actually see the myopian glands and look for any dropouts. So some of the signs of MGD is low tear breakup time, obstruction of the myopian gland orifices and metaplasia, dropout of myopian gland acini, increased staining with rose bengal and or fluorescein. Symptoms of burning increasing while reading, this is quite common, and you can ask the patients if their eyes start to burn, if they are reading for a prolonged period of time or looking at the television. Declining visual acuity after a blink, resulting in difficulty with visual tasks, especially reading. So you can, when you examine the tear film, you can actually see that there is a lipid contaminated mucin which accumulates in the tear film as particles and debris. You can see that there. Reduced marginal tear meniscus, generally the height is more than 0.5 mm. You look at the cornea, you can see punctal epithelial erosions, and sometimes you may even see filaments which are strands of mucus and debris get from the epithelial cells. You have various tests, diagnostic tests. You have tests for tear secretion like the Sherma 1, 2, phenol red thread, etc. You have tests for tear stability. You have invasive breakup time and non-invasive breakup time. And for tear film integrity and epithelial integrity, you can do the rose bengal staining. You can also use tests for osmolarity, pH, evaporation rate. And you can do advanced tests also like chemistry and histology, but it's not very common. But a word of caution, always do the biometry and dry eye assessment on separate occasions. So somebody was asking about patients that come in on the same day and want surgery. So if there is a history of dry eye or you think that the patient has a dry eye from the history, then probably you can schedule the dry eye assessment and the biometry on separate days, because if you do any invasive tests like a Sherma or invasive TBUT, then it is definitely going to affect your biometry and your calculations are going to be off. These are some of the non-invasive dry eye evaluations. You can do myopography and non-invasive BUT, we use in our hospital, we use the SBM. This is a device from, it's an Italian company, which actually it's a nice device which you can use for non-invasive BUT. So if you want to do the biometry on the same day, then you can do a non-invasive BUT. You can also use your keratometer and a keratoscope or a tear scope to look at the tear film, the reflection, the Purkinje image. Measurement here is achieved by observing the distortion or the breakup of keratometer myods. So you can see the myods, and once they start distorting, then it gives you the breakup time and whether it's normal or abnormal. So non-invasive BOT values of less than 15 seconds are consistent with dry eye. We got this device basically because again we have this problem that the patient comes in on the same day in the morning and they want surgery in the afternoon. And then we just do this test, a non-invasive BOT, to see if the tear film is normal or abnormal, because most of them have MGD, the ones with the dry eye, and this gives you a clue about that. And if this is normal, then you can go with the biometry. You can also use the HD analyzer. We have the HD analyzer. This is from Visiometric Spain, and this gives you also the OSI, which is the Objective Scatter Index, which reflects dry eye. Again, if you have an OSI which is high here, you can see it's 11.37, and you can look at the images. The gaps are where the patient blinks. So if it's very high, like 11.37, then you have dry eye. And this is again the same after treatment. You can see the OSI has come down to 1.27. This is normal. This is abnormal. This is normal. You can actually see the tear, then the breakup when the patient blinks, and then again the tear. And if you look at the difference in the OSI between the maximum and minimum, it's quite high. Here I think it's 4.55, and here it's just 0.27. So if the difference is less, again this also gives you a clue. You can also use tear osmolarity. I think this is again a popular test using the tear lab. It's I think very common in the NHS in UK. And you look at the tear osmolarity. So normal is less than 302. Borderline is 302 to 316, and moderate to severe dry is more than 316. This also is almost non-invasive, so you can do the biometry on the same day because you just touching the tear vents because they are at the margin, you're not distorting the cornea. You'll have to treat the cause of dry eye. If it's MGD, then you have to treat MGD. If it's dry eye, maybe due to lack of thermals, ocular surface disorders, proptosis, retraction, entropy, trichiasis, pterygium, inflammation, and also systemic disorders like rheumatoid Sjogren's syndrome. So whatever the cause, you need to treat it. First line of treatment, of course, is preservative-free topical lubricants, viscosity agents like CMC, HPMC, etc. You can use hyaluronic acid, which has an advantage over other drugs because it's a natural constituent of the tear film that binds water and supports epithelial regeneration. Second line of treatment is anti-inflammatory therapy. Inflammation increases the osmolarity of the tear film. So cyclosporin A is used, so it inhibits the T cell activation and inhibits the inflammatory cytokine production. In addition, it inhibits apoptosis and increases the density of the conjunctival goblet cells. This is FDA approved. Of course, the side effects are burning and conjunctival hyperemia. Some patients do not tolerate this. But you need to put the patient at least on 6 weeks to 2 months of treatment, 6 to 8 weeks before you can see any results. The other drugs which are anti-inflammatory are tacrolimus, corticosteroids, tetracycline, and chloroquine, but these are not FDA approved. We actually published an article on topical cyclosporin and management of dry eye in patients undergoing cataract surgery and compared 3 groups. One just with topical drops, one without any drops, one with topical drops, and one with topical drops and cyclosporin. Found that the group with topical drops and cyclosporin had the best effect. Zytra is another, it's a new drug which has come out, and this is again FDA approved. So there are only 2 drugs, cyclosporin and Zytra. Zytra is Lifitegrast inhibits an integrin lymphocyte function associated antigen 1 from binding to intercellular addition molecule 1, and the mechanism downregulates inflammation mediated by the T lymphocytes. Milder forms of meibomian gland disease can be treated with lid scrubs, warm compresses to soften the meibum, slow-release tetracycline or topical azithromycin. You can also prescribe essential fatty acids like omega-3 fatty acids. There are some new devices for treatment of NGD and to improve the tear film. One is LipiFlow, which is from Johnson & Johnson. The LipiFlow activator delivers a combination of heat and gentle pressure. It massages the lids by using what is called vector thermal pulse (VTP), and the combination of vector heat and gentle pressure removes the gland obstruction. And the treatment itself takes about 12 minutes, and the normal gland function recovers. Maximum results are again 6 to 8 weeks. So many times, patients with dry eye, you'll have to explain to them that it's better to postpone the surgery for a couple of months, take the treatment, and then they are much more comfortable. You have more accurate biometry and better post-op results. Then the other treatment is intense pulse light therapy, or what we call IPL, light of 500 to 1200 nano wavelength is used based on the skin type. So you should be careful. The darker skin type, you can get some skin burns, and this basically uses a xenon lamp, and mechanism of action is it causes coagulation of the telangiectatic vessels, opens up the meibomian gland orifices, and there is also thinning of the meibomian because of the thermal effect. And even with this, you have to wait for at least 2 months, 2 to 3 sittings before the tear layer normalizes. Of course, in very severe cases, you'll have to surgically manage it or refer it to your oculoplasty surgeon. Punctal occlusion, you can do it yourself to reduce tear drainage. Tarsorrhaphy, canthoplasty, transplantation of minor salivary glands, mucous membrane graft. These are all more complex procedures. Punctal occlusion is something that you can do. It's temporary. The punctal plugs are made of collagen, last for 1 to 2 weeks. It's reversible. You have silicone plugs and you have the smart plugs. So we use the smart plugs in our clinic under topical anesthesia, just under the slit lamp. You can just insert them, one size fits all. It dilates because of the increased temperature, and there's no need for a punctal dilatation or different sizes. That's quite easy to use. Of course, let's skip the advanced procedures. To sort of conclude, surgeons need to keep in mind that the ocular surface disease may affect as many as 1/3 of patients with cataract. In addition to discussing surgical and technology options with patients such as flags or multifocal lenses, patients should also be counseled about the potential impact of OSD. It can impact your biometry, and it can cause increased dry eye and dissatisfaction post-op. Especially in patients who are unaware that they have dry eye, it may worsen after cataract surgery, and they may blame the surgeon for the symptoms. So you have to be very careful about this. Thank you very much.